Still, we remain in the midst of a crisis of drug-related harm. There were nearly 107,000 people who died of an overdose in the latest year for which we have data, and it's probably around the same now. Most of these overdoses are caused by opioids or opioids in combination with other drugs, and increasingly opioids in combination with other drugs and stimulant-related overdoses are rapidly increasing as well. The overdose, both fatal and non-fatal overdoses get a lot of attention, as they should. But we're also seeing increases in people who are contracting diseases and being harmed from injection related causes, right? So infections related to endocarditis, hepatitis C, and just injection related injuries are all increasing. Many of these deaths and injuries are preventable, right? As we're going to talk about today, a lot of them are caused entirely or at least exacerbated by what is sometimes referred to as the war on drugs in this country. Now, we recognize that there's no silver bullet, right? There's no one weird trick that's going to solve the overdose crisis and the crisis of drug-related harm. We think that there are a lot of opportunities to change the law and policy related to, drugs in the United States, to move to more evidence-based, we call person-centered laws and policies. Yeah, so it's a kind of level set. Like, what are we trying to do here? I mean, this is the question that we are always asking ourselves, and we think policymakers should be asking themselves, right? There is this sort of tautology, right? It says every system is perfectly designed to produce the results it's producing. So it never makes sense to say, well, the system isn't working. The system is working. The system is producing exactly the results that it is designed to produce. The question is just whether we like those results or not. If we do like those results, then we should continue with what we're doing. If we don't, then we need to change it, right? So when you look at the war on drugs, you see, what is it producing? Well, it's producing human suffering, right? It's producing dead people, hurt people, destroyed families, right? And it preferentially targets, which means that it has a greater negative effect on people who are already in need of some extra help, right? People who are already stigmatized, particularly non-white people, economically disadvantaged people, and so on. We're going to talk about the harms of incarceration, which are bad, and public health harms, which are terrible. But there are also lots of other, we call negative externalities, right? Bad things that come from the war on drugs. People who want to work, are capable of working, but cannot find work because of laws that prevent them from doing that. Families ripped apart, traumatized children, and so on. We say to each other here at the Legal Project all the time, the war on drugs ruins everything. Now you say, okay, well, it's why do you like to complain all the time? It's easy to complain. Look at all of the nice things that are happening. And that's true. Some policies have improved, right? It is now, less hard to get methadone for opioid use disorder, buprenorphine for opioid use disorder. It is easier to get naloxone. In some places, it's easier to get syringes, and so on. This is true. Those changes are positive. We love them. We love all of the advocates that have worked to make them happen, the policymakers that are responsible for them. Those are great. We don't want to in any way diminish those positive changes. But we do want everybody to recognize that all of those changes are largely tinkering around the edges of American drug policy, right? drug policy remains largely directed toward creating and maintaining, you say, a permanent underclass of criminalized, stigmatized people who use the wrong drugs or who have used the wrong drugs. We think reform is necessary. We think it's possible. So today we're going to talk some about the current state of the law, and then we're going to talk a little bit about where we think law should be going. So I want to really quickly introduce our presenters today. I think that some of you have been around for a while, kind of think of me as the legal project. Not the case. We are a small but very mighty team of 3 fantastic attorneys. You're going to hear primarily from the other 2 attorneys here today. So we've got Ashley Dennis, who is a staff attorney with the project. We've got Amy Lieberman, senior attorney with the project. And then you do need to hear a little bit from me. They let me run the place. So this is what we're going to talk about today. We're going to go through naloxone laws, state laws related to drug use equipment. I'm going to talk a little bit about Good Samaritan laws, some reflections, some thoughts, and then we're going to have Q&A. So with that, I'm going to turn it over to Ashley, who's going to talk about naloxone access laws.
And who is first going to figure out if I can redo the sharing of the screen. Okay. Amy and Corey, can you see the thing the way it's supposed to look? Cool. Okay. Hi, everybody. My name is Ashley, and I'm going to advance these to the right spot. Maybe if I can figure it out. Here we go. I get to talk to you about naloxone. I'm so excited that there's a lot of people that we know, and there are so many people that we don't know on this webinar. So to start with, we're going to talk about what is naloxone, because who knows if everybody knows what naloxone is. We all know, harm reductionists know, lay people call it Narcan, but naloxone. So it's a pure opioid antagonist. So what does that mean? During an overdose, it attaches to the opioid receptors in the brain. So those already have the opioids in them. And what it does is it knocks them out of the receptor. And so in doing that, it reverses and blocks their effects. So that's what that's doing. That's what that means. That's what it means. And so it was discovered and patented at the beginning of the 1960s, and it was approved by the FDA in 1971. And then the WHO added it to its list of essential medicines in 1983. It has no effect on non-opioid drug overdoses, so it's just for opioids, not for others. There's no dependency potential, and it has a high safety margin. It safely and effectively reverses opioid overdoses if given in time. So it's time limited because it's about people's breathing. And so this graph shows how long it takes before it gets unlikely that somebody will recover. So that's the basics of what is naloxone. Some myths: if you give someone naloxone, they're going to wake up violent. And so it's really unlikely somebody's going to wake up violent, but it's likely that they're going to wake up extremely uncomfortable and in pain, because if they're using opioids, they might be going into precipitated withdrawal. We're going to talk about what those symptoms look like later. And if they were you would also not want to experience those things. So being a calming influence and non-confrontational, if you're giving somebody naloxone, is going to do wonders. Some of the others is if I touch someone who used fentanyl, I'm going to overdose. That's a big one we see. It's a big one we see coming from law enforcement of, I touched it and now I'm overdosing. That's not true. The casual skin encounter is not going to cause you to overdose. If you're performing rescue breathing, you should use personal protective equipment. But if you've just administered naloxone, so you're just giving somebody Narcan, putting it up their nose, I was just showing folks what it looks like. So if you just are putting it up somebody's nose and you're worried that maybe you touched fentanyl around, don't panic, just go wash your hands. You're gonna be fine. And so the last one is that the more naloxone, the better, which is also not the case. So if a person is breathing and they haven't woken up yet, you don't need to give them naloxone. The problem is if they're not breathing. If after 2 doses, the person is still not breathing, it's possible that there's something else depressing their respiratory system that isn't opioids. So it could be benzodiazepines or xylazine. So again, after 2 doses, if something's not happening, there might be something else going on. And so giving somebody more causes them more likely to go into those withdrawals that we'll talk about a little bit later. And now the law, because we're attorneys and we get to talk about the law. So as of August 1st, 2013 or 2023, all 50 states and DC have some sort of law that reduces regulatory barriers for naloxone. So prior to last summer, naloxone was only available by prescription. So that's why there needed to be laws that were decreasing those barriers. So since about 2017, all states in DC have had some sort of law, and they keep getting better every year. So as of right now, there's 39 states that allow lay distributions. There's anybody out can distribute naloxone in 39 states. There's 16 states that allow possession without a prescription, and there's 11 states that allow pharmacist prescribing. We'll go into a little more detail on a lot of these in the coming slides. And so also most states have changed their references to naloxone as some version of opioid antagonist. So either they'll have already existing and they'll say opioid antagonist and they change it to include more products than just naloxone, or have changed it from naloxone to opioid antagonist. And then most states have updated their standing orders, which I'll explain what that is and about it towards the end. And we're super excited. Some formulations of naloxone are now over the counter. So that's Narcan was approved in March 2023 in the 4 milligram formulation. We were all really excited. And then a few months later in July, Revive was approved for over the counter, and that's in the 3 milligram version. And we're really, really excited. But that is to say that it's just these formulations that are currently over the counter, and they're generics. So there's still the 0.4 milligram injectable that a lot of programs use is still prescription only, as well as Floxido, so the 8 milligram version of naloxone. Those are still prescription only. So just keep that in mind. Very exciting. We want all of them to go over the counter, but currently it's just these two. And so one of the changes has been, as I mentioned, going from naloxone to opioid antagonist, or expanding the definitions of opioid antagonist. So Nebraska is the only state right now that just uses naloxone, and it's what we used to call naloxone access laws. So it's just naloxone, not opioid antagonist. Every other state has some version of opioid antagonist, and some use different. Every state has a different definition. It'll say FDA approved, it won't say FDA approved, or it'll call it an overdose reversing medication or an opiate antagonist. So every state, except Nebraska, has some sort of more expansive term. And the makers of Opti and Divior have been advocating for these changes because it makes their product nalmefene, it would encompass their product instead of just naloxone, which is a lot of the other states. And we'll talk more about later as well. And so, for example, this is Maine's state. So comparing the law before October 2023, when the law changed, to now, which is effective as of October 2023. So their state law went from just naloxone hydrochloride in their naloxone access law, so just all of the barriers that they were reducing only applied to naloxone, to or another opioid overdose reversing medication. And so their definition means it's a medication approved by the FDA for the immediate treatment of an opioid overdose. So that's even more expansive than opioid antagonist, because that's a more technical term than just any medication approved by the FDA. And another example is from, this is North Carolina's statute. So they, in May of 2023, changed theirs to, so it's already said opioid antagonist, but it only had that definition as meaning naloxone approved by the FDA for overdose. And in last year, they changed it to mean any, like an opioid antagonist, meaning any FDA approved opioid antagonist. So why does this kind of make us nervous? So nalmefene and other high-dose naloxone products can be harmful. Many harm reduction programs, including those in areas with high fentanyl penetration, find that the 0.4 milligrams of intramuscular naloxone remains effective. It's not, naloxone does not last as long as nalmefene. So nalmefene is it lasts longer in somebody's system. And so that makes somebody more likely to have precipitated withdrawal and for longer. And so those symptoms include diarrhea, nausea, vomiting, runny nose, goosebumps, chills, headaches, imagine like all of that all at once. That's what's happening to somebody. Some more serious risks include pulmonary edema, tachycardia, and increased risk from overdose from attempts to overcome those withdrawal symptoms. So using to try and overcome those withdrawal symptoms. Same thing with higher dose naloxone products. So in a February 2024 study, they showed there's no benefit to using the 8 milligram compared to the 4 milligram. So it's more likely to cause that withdrawal and make somebody feel that absolute garbage than just using the 4 milligram that already exists, or even the 3 milligram Revive or the intramuscular naloxone. So there's no benefit to increasing these products or increasing different types of products. It's just we use the naloxone, we know it works. And all of this causes folks to avoid using Narcan. Like nobody wants to get Narcan because you're going to risk having these withdrawal symptoms, and it causes avoidance by people who use drugs. And I'm sure anybody on this call, even if you're not a person who uses drugs, would probably want to avoid all of the symptoms because nobody wants to feel that way. You don't want to feel that way when you have the flu. So yes, avoid this for people. It would be great. And moving on to, again, back to the law. So as of August 1st, 2023, 39 states allow layperson distribution of prescription naloxone. So that's allowing folks that aren't medical professionals or in the medical field to distribute naloxone, even if it's a prescription-only medication. It allows people to get that out. There's 16 states that allow possession without a prescription. So you can have it and not get in trouble for having, most drugs you can get in trouble for not having a prescription. So there's 16 states that allow that, which is up from 12 in 2020. So in the last 4 years, that's 4 states. And there's 48 states that have explicit civil immunity for administering naloxone, which is up from 45 in 2020. So what that means is that you can't sue the person for giving them naloxone. The truth is the people that are getting in trouble for this are people that the police are already wanting to get in trouble anyways. Naloxone is just a life-saving drug. Like nobody's out there just Narcaning themselves when they're not using an opioid or using, it's not, nobody's using it for that. That's not what it's for. It's meant to save lives. So if folks are going after people with naloxone, it's just, that's not a good look. It's really not a good look. And we don't know of anybody who's been prosecuted for naloxone. It's always the case, somebody might sue somebody for something, is I believe what Amy likes to say. But again, it's not going to hurt somebody experiencing an overdose. There was a case in California where somebody's, the EMTs broke into this man's car and gave him Narcan, and he's now suing the EMT company. But it's not because he was significantly harmed by this Narcan. It's because he was understandably scared and frustrated that somebody broke into his car. He wasn't experiencing an overdose. They Narcaned him. That's a very stressful experience. And he's suing them. But that's not the norm. Not the norm. Very rare case. And it's an example of somebody will sue somebody for something. The person that it happened to was an attorney. And attorneys are much more likely to sue somebody for something, even if there's not necessarily a lawsuit there. Which brings us to vending machines. So since there's a lot of states that allow that distribution without a prescription, that means that there's increasingly, we're seeing more folks being super ingenious and putting them in vending machines. So the one on the far left is more like a newspaper style. So you can pull it out, grab your Narcan, or your naloxone, your Revive. The ones in the middle are more like a traditional vending machine like you see in hospitals and airports. And then the one on the right is like a smart vending machine that have more buttons and things you can click and options. They're really cool. I got to play with one at APHA. Whenever I see one, I like to take pictures with them because they're so fun. And it's a great way for people to be able to use them anonymously and at different hours. So if it's just out there, then folks don't have to worry about going into a program that's only open from 9 to 5 or at hours that don't work for them. The specifics differ as far as how the law is in each state, but for the most part, if you can distribute naloxone freely in your state or under a standing order for the over-the-counter prescription, you can put it in a vending machine. It's for the OTC version, it's similar to like when you see Tylenol or Tums in a vending machine. And then for a prescription, a lot of the time under the standing order, the way the language is can make it so that it's okay under a vending machine. If anyone has questions and wants to put a vending machine in their state or wants to talk to us about what the specific law is in their state to be able to do this, please reach out to us. We would love to talk to you about it. That's what we do. So please reach out to us to talk about it. And then, so medical professionals also get liability protections. So there's 11 states that allow pharmacists prescribing of naloxone. So As y'all probably know, usually it's your doctor that's prescribing something, not your pharmacist. And so there's 11 states that specifically allow pharmacists to prescribe naloxone, which is up from 8 in 2020 and from 5 in 2016. So again, we see that increase. There's 43 states that have explicit civil immunity for prescribers and dispensers. So again, that anybody will sue anybody for anything. And so that's up. That's the same as in 2020, and it's up from 36 in 2016. And then there's 36 states that have explicit disciplinary immunity. So civil immunity is like person to person type immunity rather than like criminal immunity. And then disciplinary immunity is for things like the State Board of Pharmacy or something like that. So they can't get in trouble with their employer or their larger governing structure. And so that's remained the same since 2020, and it's up from 31 in 2016. And more medical things, naloxone insurance coverage mandates. So as of April 1st, 2023, there's 7 states that require private insurers to cover naloxone. So those states are Arkansas, Colorado, Illinois, Missouri, New Jersey, Rhode Island, and Washington. A lot of other insurers provide coverage. So this isn't a full list of all of the states that are states that have insurers that cover naloxone. Lots of insurers do that. They just they're not mandated. They don't have to do it by state law. So this shouldn't be a full list of where naloxone is covered by insurance. If you're interested, you should talk to your insurer and definitely find out if they cover it, because insurance coverage is great. And insurance can also provide coverage of over-the-counter naloxone. So we encourage insurers to cover that, because now it's over the counter and it's great. And it would be great if it was covered, because that's really expensive. That like $45 in some states, it's a lot. There's also 5 states that have lowered access barriers when insurance covers naloxone. So it doesn't mandate the coverage, but if it is covered, it reduces barriers. So in Connecticut, Delaware, Maryland, and New York, there's no pre-authorization requirements, so they can't require pre-authorization. And then in Minnesota, if the plan covers prescriptions, it has to cover prescriptions for opioid antagonists, and it also has to include within that coverage, it has to include opioid antagonists that were prescribed by the pharmacist. And again, in this language, there's also that opioid antagonist language, which means that it's possible that those insurers could just cover, because a lot of language requires just covering at least one opioid antagonist, it's possible they could make the decision to just cover naloxone or just cover one specific formulation. And so that makes us a little nervous, because we want it to cover naloxone all over the place. And last, we'll talk about standing orders. So again, because there's now so many people on this webinar that we don't know where your background is, what is a standing order? So most naloxone laws allow any prescriber to issue a non-patient specific prescription, which is what a standing order is. So it's a prescription that is meant for just any, like it's not meant for like Ashley Dennis has prescribed the prescription. It's meant for predetermined people. So it's usually in the standing law, it's a person likely to experience an overdose, or a person who will likely be in a position to assist a person experiencing an overdose. It usually also includes first responders, school employees, harm reduction programs, employees, and their volunteers. And some are just super broad of like anybody, come get your naloxone, which is great. And then many have issued statewide standing orders that apply to all entities in the state, but they're subject to certain requirements. So usually it'll be that the pharmacist or the person receiving the naloxone has to complete a training prior to the dispensing or the receiving. So sometimes that's like a continuing education for the pharmacist, or a training program for the person that's going to receive it. So sometimes the pharmacist has to provide that education. So teaching the person how to administering it, the importance of calling 911, and how to identify and respond to an overdose. So basically how to give that naloxone. And then again, sometimes only dispensing to predetermined individuals. So a lot of them are expansive with the person likely to experience or a person likely to assist, but there's some that are more restrictive. So they're just restricted to just first responders or just school employees. It just depends on the state. Some states have protocols or collaborative practice agreements that are like the functional equivalent. So protocols are issued by the Governing Board of Pharmacy, and the collaborative practice agreement are agreements between the prescribers and pharmacists. And so they end up doing the same as a standard. And here's some of the characteristics. Since August 1st, 2023, 47 states have some form of standing order, protocol, or collaborative practice agreements. That's almost all of them. Most states have also, in their standing orders, changed from naloxone to some version of opioid antagonist. Again, that kind of makes it more expansive. A lot of them have limited formulations. So it'll just be 4 milligram or 8 milligram naloxone nasal spray, which excludes products like Revive, or it'll have that plus the intramuscular versions. Sometimes it's just nasal spray. There's also quite a few that have outdated products. So a lot still reference the Evzio, which has actually been discontinued as of, I believe, 2020. And then some states have specifically updated it to include nalmefene and Opti specifically. So that's what that's like. And where do we go from here? How do we improve? How do we get better? So increasing the saturation of naloxone. We know naloxone works. We don't need more products. Specifically in communities where it's most likely to be used, that's where it should be going. That's where we should be getting it. We don't need more. We don't need more types. We don't need more formulations, more products. What we have works. It needs to get where it needs to go. There's very limited funds on for harm reduction programs or for folks in general. And so it shouldn't be spent on creating new products that can do more harm than good. It should be getting those products that work to the people that need it. Another thing that would be great is to increase liability protections, especially related to lay distribution and possession without a prescription. Again, nobody's out there just like narcaning themselves. If they are, it's probably because maybe they think they're overdosing, and just let's save lives. Get it to everybody. So increasing the liability protections for the lay distribution, and then also for just non-medical folks. So folks in recovery homes, in recovery programs that want to be able to administer, but maybe their employer or the organization is worried about that liability of administering. So increasing those protections for folks is really important. And then increasing the state laws, again, that permit that lay distribution. So there's only 39 states that explicitly permit that right now. We'd like to see that to be all 50. We want all 50 states to be able to distribute naloxone to anybody that needs it. And then there's only 16 that allow possession without a prescription, which again, it's over the there's options over the counter now, but that injectable naloxone that a lot of people like and is a lot more cost effective is still prescription only. And so we'd love to see that get that possession without a prescription in all 50 states so that more folks can use the product that works for them and that we know works in the community. More insurance coverage mandates that require naloxone specifically or patient choice. So if they require naloxone specifically, then we don't have to worry about those high dose that are concerning or the nalmefene that's concerning. And then allowing for patient choice allows that person to pick. So I want that Revive, I want that 3 milligram versus if for some reason you do want another product. So say you're not a person who uses drugs and you want that on hand and you want a different product. Because again, that opioid antagonist leaves room to cover just nalmefene. And so for people who use drugs, it's most likely not what they're going to want. And so if they don't have that choice, then it's really not as beneficial for them as it could be. And then move everything over the counter. Again, let's make it freely available, give it to everybody. It's not doing anything to anybody, it's just saving lives. And with that, I will pass it to Amy. And we'll do questions at the end if we haven't already said that, because I know there's probably lots of questions.
Yeah, hi. I want to reiterate what Ashley just said. There's some really good questions coming in that we'll address at the end. There's also some interesting questions in the chat that the chat is really busy, which is great. I'm glad people are talking. But if there's a specific question you want us to answer, please put it in the Q&A section so that we can actually see it, since we're not totally monitoring the chat the entire time. I'm going to talk to you about injection, smoking, and drug checking prohibitions. This is the artist formerly known as drug paraphernalia laws. Of course, they're still known as drug paraphernalia laws in the actual law. We're trying to move away from that because paraphernalia sort of indicates that it's something extra, something that's unnecessary, and it has a negative connotation to it. But as we know as harm reductionists, everything that you use to inject, smoke, snort, ingest drugs in any way that makes it safer is necessary and is something that you should be able to access. So to give you a little bit of background on the relevant law, prior to 1979, drug equipment was not illegal in most states, but our friend the DEA created a model law that defined essentially anything that you could possibly use with illicit drugs as paraphernalia. And many states have adopted that model. However, over time, some have created exceptions, such as for syringe services programs or for drug checking equipment, which has resulted in a patchwork of paraphernalia restrictions all across the country. The DEA model law was designed to be intentionally extremely broad. When you read it, it's a very outdated law. It's clear the drafters mostly had head shops and cannabis in mind. It was never designed to impede syringe services programs or access to public health tools, which they didn't exist at the time. A couple outlier states that never bought into the DEA model law include Alaska, which has never passed a paraphernalia law, but some municipalities within Alaska have. Arkansas, Illinois, and Ohio, possession of paraphernalia is illegal, but free distribution to adults is not. In Massachusetts and Michigan, possession and free distribution are not prohibited. Nebraska, other types of paraphernalia have always been prohibited, but drug checking equipment has never been illegal. In New Hampshire and in Rhode Island, they're sort of part of the early transition to removing syringes or injection from their drug paraphernalia laws. In New York, possession is not legal. It is not illegal, but delivery is. South Carolina, syringes are not listed in the definition of drug paraphernalia, although the distribution and possession of drug paraphernalia is illegal. And in West Virginia, the only thing about drug paraphernalia that's illegal is selling it to minors or at festivals. As you can see, it's a wild ride, these laws. The paraphernalia laws in each state come with a general format. Usually there's some sort of definition section. For instance, any equipment, products, and materials which are used, intended for use, or designed for use in testing, analyzing, ingesting, inhaling, injecting, manufacturing, all kinds of different gerunds there. A controlled substance, or I guess that's a verb, a controlled substance in violation of the law are considered drug paraphernalia. Then there's the section that says what it's illegal to do with drug paraphernalia: use, possess with intent to use, sell, deliver, manufacture in violation of the law. And then there's usually something that describes what kind of crime it is to do these things, what the penalty is, and then there may be exceptions. The definition section usually includes things like injecting, inhaling, testing, and analyzing, which are sort of the four big ones that we have been focusing on in the harm reduction world. And sometimes they specifically mention syringes or specifically mention pipes used to ingest stimulants. And they usually contain a catch-all at the end of this list that says, or otherwise introduce into the human body, which can make things a little bit confusing. For example, New Jersey's law has never included the word injecting, but the definition of what drug paraphernalia is includes that catch-all phrase. Now, since January 2022, syringes have been specifically excluded from the definition of paraphernalia in New Jersey, but before that, it's unclear, right? What does otherwise introduce into the human body mean? Could be anything. And there's often an additional section that exists that explains how to make the determination that an object is or is not paraphernalia. Because of course, all these objects that are forbidden are things that you can use for other reasons, just not for drugs. And so that often says like, well, was it found near illegal drugs? Was it found at the scene of someone using illegal drugs, right? Basically proximity, things like that. The illegality and crime category. So obviously where it's prohibited, violations can range from infractions, misdemeanors, felonies. Sometimes syringes are explicitly removed from the definition, but the laws making it illegal to use or distribute paraphernalia still contain references to injection. people are really bad at writing laws. And sometimes it's the opposite way around. There's usually a mens rea requirement, which is the intention behind the law. So it usually requires knowledge, or that you reasonably should know that the paraphernalia that you are delivering or possessing will be used in violation of the law. The penalties is where we can see some wild variation. We see that penalties for possession range from no incarceration to 6 years in prison and no fine to a $10,000 fine. The possession of drug paraphernalia with the purpose of using it to break the law is, if the controlled substance is methamphetamine, heroin, fentanyl, or cocaine, a Class D felony in Arkansas, which is punishable by up to 6 years in prison and a fine of up to $10,000. And actually, Arkansas's law is even worse, because for drug checking equipment, for equipment used to test or analyze drugs, it's a Class B felony, which could be up to 20 years in jail and a $15,000 fine. For delivery, ranges from, again, no incarceration to up to 9 years imprisonment and no fine to $30,000. I don't know why it's so different in Idaho, per se, than in any other state, but there you could face those major penalties just for handing somebody a clean syringe. Now, sometimes the penalties for use and possession and the penalties for distribution are the same, and sometimes they're wildly different. For example, in Hawaii, both penalties are a maximum $500 fine. In North Carolina, both are Class C felonies with a maximum of 5 years. So even there's variation even within there. The exceptions are either found in the definition section or the illegality sections, or in a separate law that authorizes syringe services programs. Some common exceptions include syringes or other injection equipment, fentanyl test strips or testing equipment, more general testing equipment exceptions, but only one state has specifically removed smoking equipment from their list of paraphernalia. Although some state syringe services programs laws can be read to include smoking supplies. For example, in California, SSP staff and volunteers are not subject to criminal prosecution for the distribution of syringes or other materials deemed by a local or state health department to be necessary to prevent the spread of communicable diseases or to prevent drug overdose, injury, or disability to participants. And the California Department of Public Health has explicitly said that that includes pipes and other safer smoking supplies. Oops, all right. So why does this matter? It's often said that injection drug use is a risk factor for HIV, hepatitis C, and other bloodborne disease, but it's not. Using injection drugs is not going to transmit HIV. Using old or sharing syringes, that's the risk factor. Lack of access to new syringes is the reason why bloodborne pathogens get passed. Smoking drugs can often be a harm reduction method over injection. Many people will choose to smoke their drugs instead of injecting because they feel like they have more control over their high. Most illicit opioids now contain fentanyl. It's also becoming prevalent in some illicit stimulants. And now we have xylazine showing up more frequently, and even some other new novel drugs as well. But due to paraphernalia laws in several states, the legal status of drug checking is unclear, and most syringe access is highly constrained. Access to other paraphernalia like smoking equipment is almost completely forbidden, where access is allowed, it's usually not explicit. I mean, even good paraphernalia laws can be problematic. So say you remove syringes from the definition, but great, well, what about smoking equipment? What about cookers, cottons, sterile water, other things that you need to use in order to safely inject drugs? Oh, you removed drug checking equipment from your definition. Great, but did you only remove fentanyl test strips? Because that's not going to be enough. And is possession of controlled substances that you're using to test, is that still illegal? Because who's going to get arrested there? If you've authorized an SSP in your state or locality, great, but do they need local authorization to operate? Because I live in California. We're seeing a lot of this right now. There's a lot of problems dealing with local entities who, even though the state is saying we can, SSP can operate in their area, the local authorities don't want to agree to that. Also great, but are participants as well as staff protected? Up in Idaho, the law there really didn't clearly say that if you obtained paraphernalia from an SSP, you would be you would have the same kind of immunity as those who are handing it out. Also, smoking supplies are important. And why? Why are we distinguishing between the sources of where you get this equipment? That leads to a lot of confusion and a lot of problems. Like, for example, folks in Florida right now are being prosecuted for syringes that they got from an SSP, which is allowed, because they can't prove that they got them from an SSP. There are, I put states, but it's really just one state, taking bold steps. Minnesota did a full repeal of drug paraphernalia crimes in August 1st, 2023. Use and possession with intent to use drug paraphernalia was repealed. Separate law was modified to remove prohibitions on all syringe-related activities other than sale. A limit on the number of syringes that can be sold from pharmacies was removed. Language that prohibited the delivery of drug paraphernalia was removed. And the drug possession law was modified to exclude possession of a residual amount of a controlled substance in drug paraphernalia. However, even this is facing pushback. There's already local communities passing local ordinances criminalizing paraphernalia, and the residue exception is only for a 5th-degree possession crime. Having residue near a school zone would still count as possessing any amount of drug, which is a 3rd-degree possession crime. It's still illegal to manufacture for delivery or sale, and it's still illegal to deliver drug paraphernalia to a minor. I mean, you may have seen this meme on the internet. We're looking at one syringe that's legal, one syringe that's illegal. They're the same picture. What's the difference? Almost everything that falls under the definition of drug paraphernalia is something that can be used for another purpose. So the only difference I can see between terming something paraphernalia and something not is to cause harm. Drug checking is another big area in paraphernalia law. Between 2020 and 2022, there's been a rapid adoption of DCE permissions, so exceptions from the paraphernalia laws to include things like fentanyl test strips, all drug tracking equipment, or test strips that can be used for certain drugs. But this is playing whack-a-mole, right? This is always going to be addressing last year's problems. States that authorized only FTS are now facing xylazine or other novel drugs in the illicit drug supply. And while arrest and prosecution for drug tracking equipment is rare to non-existent, these laws discourage distribution and use of DCE, especially by, gun-shy government officials. So how do we reform safer equipment access? SSPs were great, and they are great. They were once a very progressive idea, but in practice, they generally only permit SSPs to work with local authorization. They involve complex paperwork on behalf of the people who are operating them, over-regulation, and they don't ensure support when SSPs come under local attack. And so these flaws in these laws can render SSP authorization laws almost useless. Removing certain devices or equipment from paraphernalia laws can be helpful, but can't predict what's coming next. So a full repeal of paraphernalia laws is really the only way to address the needs of people who use drugs, who want to use drugs in a safe way, and all people in our communities. So why decriminalize paraphernalia? Criminalization of everyday objects when they're used to consume drugs makes life as a person who uses drugs infinitely more difficult and confusing. Criminalization increases health risks to people who inject drugs and everyone else in the community, including law enforcement. And it costs money. Laws that cost money and make people less healthy are bad. There's other specific benefits to paraphernalia decriminalization. less stigma, keeping people from seeking help or reducing their harm, less litter, because turning in used equipment won't result in penalties, so people will have more of an incentive to do so. Less bloodborne pathogen transmission, less healthcare provided on the taxpayer's dime, less incarceration, more connection to treatment, more knowledge of safer drug practices, more options for how someone chooses to use drugs, more equity, removing extra charges that law enforcement may add on a whim, and more funding available for other programs that can help people use drugs. The area is really ripe for decriminalization. The DEA pushed states to enact this extremely broad paraphernalia law, and they could encourage them to modify or repeal that law. Nothing to that effect is on the table, but states can and have removed criminal penalties for safer use supplies. You know, as we've seen a lot of progress, we see a lot of backlash as well. And now we have states as varied as Idaho, West Virginia, and California seeing threats to SSP authorization laws or local SSPs. So what's the new beginnings? Decriminalization of equipment used to consume drugs should only be the starting point, not the end point. Once we've stopped discouraging paraphernalia access, then we need to take proactive steps to encourage it. Funding harm reduction programs, developing innovative products. For example, the hammer pipe was developed by people who use drugs to make smoking heroin easier so folks could have a better option than injection. Removing obstacles like local NIMBY regulations. Teaching harm reduction practices to learners from many fields, medicine, nursing, law, social work. And of course, the end goal, decriminalizing drugs. Thanks, I'm gonna pass it over to Corey now.
Great, thanks so much, Amy. Folks, how lucky am I to get to work with these two great lawyers every day? So I want to quickly talk about overdose Good Samaritan laws, and then we are going to have a little wrap up here. So overdose Good Samaritan laws. So what's the idea here? Well, you know, as we've been discussing, the war on drugs criminalizes nearly every aspect of drug use. It has permeated all aspects of law and regulation in the United States. Because of that, people who are present at an overdose are often hesitant to call for help. Why? Because they're going to identify certainly the person overdosing and possibly themselves and other people who are there as a person who uses drugs. And in the United States, a person who uses drugs is a bad person, literally a criminal, okay? So people feel that, you know, calling 911, having armed agents of the state come to the scene may not be the best idea. Now, we think so little of putting human beings in handcuffs and cages in this country that we actually don't keep great records of who we're doing that to. But we do have some published data on how many 911 calls or, you know, overdose calls to authorities result in someone not just being arrested, but being incarcerated. There was a paper published last year with, you know, data from Indianapolis that showed that approximately 10% of every overdose call resulted in someone being incarcerated. And there's, you know, survey data that shows about 1 in 5 law enforcement agencies report that overdose calls result in incarceration, right? So, of course, people are afraid about calling 911 in an overdose. That's a perfectly natural reaction to a state that is literally, is designed to punish them, to criminalize them, to incarcerate them, right? Now, to encourage people to call for help in an overdose, almost every state, 48 states, have enacted laws that provide some immunity, some criminal liability protection to at least some people at the scene of an overdose. The idea here being to encourage people to call 911. You can see the dramatic increase in these laws over time. So here's a map of where we were in 2015, where we had 33, 34 states that had one of these overdose Good Samaritan laws. By 2019, we were up to 47 or so, and we've basically stuck there ever since. For those of you who are wondering who the holdouts are, they are Kansas and Wyoming. Now, in general, these laws have become more protective over time. There are two main ways that that's happened. The first is that some laws have been modified to provide protection from arrest. So initially, some of these laws only provided protection from prosecution or sometimes conviction. And those words, sometimes are kind of viewed as synonymous by non-attorneys and people not in law enforcement. But those are actually terms of art, and the importance can be very different. Right? If you have a Good Samaritan law that says that you can't be convicted or can't be prosecuted, you can still, you've called 911 at an overdose scene. You're trying to do the right thing. You're trying to be a good friend. The police could come, give you a hard time, put you in handcuffs, put you in the back of the police car, take you down to the station, take your photograph, book you. Maybe it's a Friday night. Maybe they keep you there for the weekends until, the local ADA can take a look at your file on Monday. And then he says, oh, we got to let this person go. Meantime, you spent 48 hours in the county jail going through withdrawal. That can be that's why it's important to expand the law to protect from an arrest, not just charge of prosecution. A bunch of other states have also modified their laws to provide protection from violations of probation and parole. Now, sometimes people get this a little confused and they will say something like, our Good Samaritan law doesn't protect people who are on probation or parole. Now, because states are always looking for ways to mess with people, that is true in a couple of very specific states. But in general, that's not true. What has happened is that a number of states have added that just the mere fact of being at an overdose scene is not in and of itself enough to violate somebody's probation or parole or to resentence them, because a lot of probation and parole terms have this these broad requirements that you not be around people doing crime, not be around people doing drugs, and so on. And because, the war on drugs targets people who use drugs, it is not uncommon for people who are using drugs or who are at the scene of an overdose to be on probation or parole. So those are good. That's great. That didn't just happen. That happened because advocates identified that these were shortcomings of the laws and pushed to get them changed. That's great. The problem is that almost all of these overdose Good Samaritan laws provide very limited protection from criminal laws and no protection at all from other negative legal actions that are, often, levied on people who use drugs. Almost all of them are limited to very minor drug-related crimes, no protection for other offenses, not even other minor offenses, things like, failure to disperse, failure to follow a lawful order, trespassing, and a million other things that people who use drugs are sometimes subject to at the hands of the state. Of course, no protection from things like, somebody calling Child Protective Services, your landlord moving to evict you, and all of these other things. Academic evaluations of these laws are a little, most find a mild protective effect. It seems like that effect increases the more protections the Good Samaritan law has. But of course, we see the same racial gradients that we see with criminal law in general. Now, I wanted to point out a couple of particularly egregiously bad Good Samaritan laws. You know, and I actually hesitated to do this because we're always concerned about giving bad actors bad ideas. But I do want to just sort of demonstrate where lawmakers are coming from, right? The idea behind a Good Samaritan law, like to be clear, is that people who use drugs are bad. They should be arrested, they should be put in jail, and if they die, they die, right? If they are willing to jump through a bunch of hoops and they're doing something that's very, very minor, you know, like having small amounts of drugs or paraphernalia on them, maybe we'll let them go. Like that is what a Good Samaritan law says, right? So that's why they're limited to certain very minor crimes. A lot of them impose additional requirements, like you have to stay on the scene, you have to cooperate with police, you have to provide your name, and so on, which again, if your goal is to make sure that all possible lives are saved, that everyone who overdoses gets the benefit of, you know, trained EMS on scene as soon as possible, these aren't the kind of laws that you would write. These are the kind of laws that you would write if your overriding concern is that people who use drugs might be getting away with it. Okay, that is how Good Samaritan laws are framed. A few particularly bad ones, you know, we have a number of states that limit the times you can get immunity, you know, just once, maybe twice. You know, that's absurd, right? That's absurd. Addiction is a chronic relapsing disease. You know, the idea that, well, we want you to call 911 just once, but that's your freebie. After that, you should die. You know, that is what Iowa legislators have decided, right? Ohio legislators have decided, well, we'll save you twice. You know, this is absurd. You know, or again, this is the kind of law that you get if you are driven by the desire to harm people who use drugs, okay? Now, again, we're not totally doom and gloomers, right? There is one state that we think is on the right track, okay? And it's Maine. So Maine previously had a kind of run-of-the-mill, you know, normie Good Samaritan law, right? It looked a lot like all the other Good Samaritan laws. In 2022, there were a number of drug law reforms in Maine, championed and pushed by Maine folks, people in Maine who convinced, you know, their legislators, some of them were legislators, you know, to kind of change the thinking, you know, to like, we're asking that question of what are we trying to do here? Okay. And one of the ways that shows up is in the Maine Good Samaritan law. So in 2022, Maine passed a new law that shifts the paradigm, right? So under the new Maine law, the presumption is that everybody gets immunity from everything, right? The person who calls for help, the person who overdosed, people who are rendering aid on the scene, they are immune from arrest for crimes, right? This is how you would draft a law if you got into a room and you said, okay, how do we save lives of people who are overdosing? What are people concerned about? Well, they're concerned that they might get arrested for stuff, you know? Well, let's make sure that they're not going to get arrested for stuff. You know, you can write a law like that. Maine has done it. Now, I would say the Maine law is not perfect. There are a list of 21 crimes to which it doesn't apply. I would say in general, those are the kinds of things that, you know, people on the scene of an overdose are not concerned about. They are things like kidnapping, arson, incest for some reason is on the list. You know, so in our view, there should be basically no exceptions, no to that list, but this is the right idea, right? This is where states should be moving. Okay. Now, I'd say that because, we often find that states don't want to be first. Legislators don't want to be first. And when we talk to them, they always say, well, who else has done this? Well, Maine has done this. Just like Amy talked about how Minnesota has essentially legalized the possession and distribution of equipment used for taking in drugs. You have an example there. Now you have an example of Good Samaritan laws. So, I don't think that we need to talk too much about Good Samaritan laws, particularly since, like I said, 48 states now have them. And I don't want to make it seem like we are unappreciative of the work that advocates have put into, like, including us, into helping these laws get passed. A bad Good Samaritan law is better than no Good Samaritan law at all. We do want people to recognize that most of these laws are bad. If your goal is to save lives, right? Again, every policy is producing the results that it's designed to produce, right? Why do we have so many people dying? One of the reasons is that people are afraid to call for help. Again, we don't have great data on this, but the data we have from CDC suggests that over 40% of fatal overdoses are witnessed. That should be a never event or an almost never event. If you overdose and someone is there with you, you should not die. Okay? These laws could move us closer to that happening. States should modify the Good Samaritan laws so that they are more like Maine's, right? Immunity is the default rather than the exception. Now, the Maine law is limited to criminal penalties. Doesn't say anything about child protective services. It doesn't say anything about your landlord can't kick you out. Doesn't say any of that stuff. Your law can, and it should, okay? If your goal is to save lives. All right, let me sum it up here a little bit before we move to the Q&A. So yeah, much more information is available on all of these laws on our website. We have a big document that goes through all of these laws. And when I say big, this thing is like 100 pages long, a bunch of footnotes. Anything you want to know about the laws we've talked about is there. We also have a specific one on these other topics, the Good Samaritan laws, drug checking, naloxone access, and we also have a couple other naloxone specific ones. These are hyperlinks when these slides go around. You can click on them. You can also just go to our website, just Google Network for Public Health Law, Harm Reduction Legal Project, and you will see us. We have a bunch of other information there. You can also email us with your specific questions. All right, summing it up here. There have been some positive changes. Those are great. Like, we encourage them. If you are working on changes, like, we are not going to tell you, that you suck, you need to be trying harder. We trust you to know what is possible in your jurisdiction, and we will help you, do that. So these changes are, positive changes are positive. Any positive change is good. Do you think that it is important that everybody understands that the overall legal landscape remains heavily tilted in favor of criminalization? You hear people say that we can't arrest our way out of the overdose crisis. You just hear a police chief say that we can't arrest our way out of the overdose crisis. But you never then hear that police chief say, and I am setting the goal that our police department 12 months from now will have 0 arrests for simple possession and paraphernalia, and I am holding my command staff to that, and they're going to make sure that the middle command and the patrol officers understand that. And I'm going to come back to you in a year and report that we have not arrested anybody. They never say that. And we know from the arrest data that arrests for drug crimes have remained essentially steady. We are still trying to arrest our way out of the problem, regardless of the rhetoric that you hear. Yeah. And we even see states, increasing penalties for things like drug-induced homicide, passing drug-induced homicide laws, dusting old ones off, prosecuting people for this thing called drug-induced homicide, with increasing penalties for things like fentanyl and all kinds of other, they're going back to the well of the, drug war. Well, if prosecuting and incarcerating people for 10 years is good, incarcerating them for 20 years must be better. In just the past few weeks, we've seen a number of jurisdictions doing bad harm reduction law things, right? You all have probably heard about Measure 110 in Oregon, which it wasn't even as robust as we might have preferred, but went a long way towards reducing some of the criminal penalties associated with small levels of drug possession. Well, the Oregon legislature, pushed by a bunch of billionaires, has decided to partially repeal that. The governor hasn't yet signed it, but that's expected to happen. You may have heard that there were raids of 2 authorized and state-funded SSPs in Idaho. Their supplies were confiscated. The health department did not respond, with a full-throated defense of harm reduction and the importance of syringe access. Instead, they responded with a letter to the governor saying that they're cutting off the funding, not just for those SSPs, but for the other state-funded SSPs, and they're launching an investigation to get to the bottom of it. And then that was followed up by a bill in Idaho to repeal the SSP statute entirely. There's another one in West Virginia. Nebraska is one of the holdout states that doesn't have state authorized SSPs. The legislature actually, passed a law authorizing them. And then, last week, the governor vetoed it, and the legislature was not able to override the veto. They needed 30 votes, and they got 27. So, again, I do not want to make it seem like we are a bunch of negative Nancys, but just do want to temper this idea that I think, we run into. People say, like, well, isn't that like in the past, everybody's, all in favor of harm reduction now. That is just, unfortunately, not the case. So again, every system is perfectly designed to produce the results it's producing, right? If we like the results that we're getting, over 100,000 people dead of overdose every year, huge numbers of non-fatal overdoses, and all of the rest. We could just keep doing what we're doing. But if we don't like those outcomes, we need to change the system, right? And I'll say that we decide to do that. Well, we can continue making these sort of incremental changes. Heavily regulated SSPs instead of paraphernalia decriminalization. Naloxone access laws instead of just making the medication over the counter. These overdose Good Samaritan laws that only protect you from really minor drug crimes. Like, we can continue doing that, or we can recognize that that is not working, right? It's counterproductive. It is wrong, right? And we can adopt policies that would actually improve lives and save money. Like, it is a choice, right? Like, we can decide as a society which of those we want to do. So, how do we do that? I mean, generating evidence is important, right? Like, we need the data that shows what things work. Like, we want to know what things work because we want to do things that work. Education is important too, but we already know a lot, right? So much of this comes down to the emotional appeals, and emotion can go either way, right? It is so important that, you know, we are out there talking to legislators, talking, you know, to folks in the community and saying, you know, like, look, you know, this isn't working. You know, we have tried to just beat them harder with the stick, you know, kick them harder when they're down, and it's not working. You know, like, we need to do something differently. I really do think that we are at a potential inflection point, right? I do not want to be crass and, you know, say, you know, like, make it seem like I'm saying, like, you know, no crisis should go to waste, but people are paying attention to this now, right? We now have an opportunity to change the way law and policy related to drugs happens in this country. And we need to, you know, we need to grasp that. We need to do it. Yeah, it's not just going to happen, right? You know, the moral arc does not bend towards justice. You know, wish that it did. It bends where people are pulling it, right? You know, it's not just going to change on its own. Change is contingent on people making the change happen. So we can shift this. You know, the United States is an outlier in the number of people that we incarcerate in general and the number of people that we incarcerate and arrest for drugs specifically. Our peer nations think that we're bizarre, you know, and we are bizarre, right? You know, there's nothing natural or normal about how we treat drug use in this country. We could adopt different policies. We just need to decide to do that. Yeah, so again, you know, whether the state should harm its own citizens, in my view, is primarily a moral question. And we've been talking about it primarily, we meaning, you know, our friends and, you know, people that we love in public health tend to talk about it as a public health question, you know? And it is obviously a public health question, but it is primarily a moral question. Should we as a society be harming our fellow citizens or not? Like, that is the question, okay? States can make changes. States have a lot of leeway to do, you know, the right thing. The federal government has a lot of levers it can pull to encourage and sometimes force states to do things that it wants. It's largely not pulling those levers. It can and it should. States should examine their laws and be forced to justify those that cause harm. You know, I mean, harm reduction often, you know, it's like, oh, you know, the state passes a very restrictive syringe exchange law, and, you know, there's all these reporting requirements attached to it. We have to then prove something that was proved 30 years ago. The legislature wants to pass a law saying, you know, we're going to, you know, lock people up for using fentanyl and throw away the key. Nobody forces them to justify why that's a good idea. Like, we should be doing that. You know, again, it's like shifting that paradigm. It's like changing the way we're thinking from this default to criminalization and harming people to a default of helping people. Anyway, getting off the soapbox now. We are here. Again, we are a small but mighty team of 3, and we can pull from the resources of the Network for Public Health Law, which is, you know, 24 attorneys strong. We have experts in, you know, data privacy. We have experts in, you know, local authority, all kinds of folks that we can pull from to help you get you where you want to be. So I'm going to stop sharing now. And yeah, so if you have questions, please put them in the chat. Yeah, I don't know. So I guess maybe we just want to, should we just start going through these? I mean, I see we have like a couple of questions, you know, they're kind of like in the order in which we presented, right? There are a couple of questions about dosing of naloxone. I would say none of us are physicians. None of us are pharmacoepidemiologists. I think the point that I would make there is that, I mean, a couple of things. we do know that the greater the dose given, the higher the chance that somebody is going to be put into precipitated withdrawal. Most of the real world data that we have also shows that not just the 4 milligram intranasal Narcan and generic equivalents, but the 0.4 mg per milliliter intramuscular version that's been on the market, for what, 40, 50 years, works. And it works in places that have seen high fentanyl, that are seeing like a lot of fentanyl in the drug supply. That's why we think that that is still a good idea. Our harm reduction partners are telling us that. We ask this question of them all the time, and they, this is what they say. I would also say the problem, what is overdose, right? What is opioid overdose? It's opioid-induced respiratory depression. The problem that the person having an opioid overdose is having is a lack of adequate oxygen, right? It is not a problem of inadequate naloxone, right? So everybody who's working at a harm reduction program or other place where overdoses are likely should know rescue breathing. Maybe you should have a BVM on hand, the problem, so that you can give people respiration. That is increasingly true now that we're seeing things other than opioids, benzos, and like, who knows what the next thing is going to be, right? Naloxone may not work on all of them, but breathing for somebody does, so I think those are just the points that I would make there. Ashley, Amy, do you have anything to add to that?
No, just oh, sorry, Ash. I just put in the chat a link to a policy insight that we just published recently that sort of summarizes what other people are doing in terms of research when it comes to the necessity of stronger opioid antagonists, which, spoiler alert, it's not necessary. So, and for more information, as Ashley just put in the chat, you can always reach out to us as well.
Yeah, they both nailed it. And just reiterating, please reach out to us. That's literally what we do. Ask us questions. That's our job, and we'd love to answer your questions.
Yeah, I mean, I think so. There are a couple of questions here that are getting at sort of the interaction between states and localities. That is a great question. And this is a big problem that a lot of kind of states, SSP laws, paraphernalia laws, they devolve a lot of the actual, decision-making to localities, right? So we see this all the time with syringe access programs where either, the state law just permits localities to authorize SSPs if they want, or doesn't preempt them from, banning them or making it difficult for them to happen locally. Legislatures can address that, not to get into like a con law lecture, but localities have only the powers that states want to give them. If states want to say that, anybody, state wants to repeal the paraphernalia law and say no localities can impose a local paraphernalia law, every state can do that, right? And similarly, like, again, there's this idea that state legislators have of like, well, it's just up to the localities. If they want to continue to kill and incarcerate their citizens, that's up to them. It's up to them because you let it be up to them, legislators. You can make it not be up to them.
And all of the things that we're talking about here, all of the societal harm does not care if you live in Los Angeles or if you live in Glendale or if you live in Truckee or if you live in Quincy. Those are just California cities. They don't care. I think in a lot of ways, this is exactly what state power state preemption is made for.
Yeah, so just kind of trying to look through the Q&As here. So someone asks, what is an SSP? That's an easy one to answer. Sorry about that. SSP is just the acronym for a Syringe Services Program, sometimes called Syringe Access Program, or kind of like the old school term is like a needle exchange.
Someone asked what activities we include in drug checking. Our document, our 50-state survey on the legality of drug checking equipment, sort of talks about various types of drug checking, but essentially we're looking at checking at the point of use, or at the point where you may use soon. So test strips, and that those are the things that people are mostly authorizing, right? Other types of drug checking equipment that might be like lab related or take longer. Some states have removed all testing and analyzing from their drug paraphernalia laws, and some states have just limited it to very specific individual use equipment.
Yeah, so a couple of questions about like, can we explain the laws further? I mean, yes, so there are like, there's extensive documents on our website, and like Amy said, we just email us. We are more than happy to either email you back or jump on the phone, jump on a Zoom and talk to you, you know, either, you know, just in general or about your specific situation. Caveat there, we are not a law firm. We can't actually represent anybody or give you specific legal advice, but we can explain the law in your specific jurisdiction.
There's another one about if we have a model state law for SSP, drug checking, and naloxone. As a physical document, no, but like a great starting point is Minnesota, because they've decriminalized drug paraphernalia, which gets at both drug checking and SSPs. So there's a good starting point, but no, we don't necessarily have like a specific model law.
Yeah, I think that's a great point, Ashley. And you know, thing is that like you should, if it is not illegal to possess or distribute syringes, you don't need an SSP law, you know, and that should be the case, right? There is no good reason to punish people for distributing or having syringes. So if you have a law that criminalizes that, you know, you should repeal that law. If that's not possible in your jurisdiction, you know, yes, we're more than happy to talk to you. Yeah, questions about, there's a question, are we involved in overdose prevention site legislation? If we're not directly, we're happy to explain it to folks if you have questions about what's going on. You know, yes, like there is this kind of ambiguous federal statute that would, you know, that the Biden administration, you know, the current administration is aggressively arguing prohibits overdose prevention sites or centers. You know, that would require an act of Congress to change that, or the, you know, the Attorney General of the United States, who serves at the pleasure of the president, to decide to interpret that law differently. You know, that is the kind of thing that could be solved, you know, would need congressional action to solve, you know, more, you know, in a longer term fashion, but that the executive branch, the president and his attorney general, could just decide this is not a good use of our resources, and or, you know, like we think this is a bad idea, we're not going to go after these things.
Yeah, someone asked a question about why it's legally possible for a state to outlaw practices that are recognized by public health authorities as life-saving. I think this comes back to what Corey was saying. It's that, you know, they're only going to do what they want to do, and what these states want to do is punish people who use drugs, and they don't really have any legal responsibility to listen to what public health is saying, unless the federal government decides to make a move and make a major ruling on those things, as we saw during COVID. Ashley, did you have something else to add to that?
There was a question in the chat. I would say, it's kind of hard for us to juggle all of these windows. So if you have a question, you put it in the chat, please put it in the Q&A. But someone said something to the effect of, a thing that they hear from folks is that they're worried about calling 911 because of existing warrants. Absolutely, we hear that all the time. And asked, are there any states that have protection from warrants? And I believe that there is one. Oregon has protection from warrants, but it is only warrants for crimes for which the Good Samaritan law itself provides protection. So it goes back to that, very limited criminal protection provided by the law. So yeah, it's another great place for reform.
Someone in the Q&A asked about overdoses from smoking increasing in the last couple of years. We haven't done any research on this, but what I know anecdotally from programs that I work with in Los Angeles is that just more people are smoking. More people have chosen to move away from injection drugs and have chosen to smoke drugs instead. And so necessarily that means more people are going to die from overdoses that involve smoking.
Yeah, it's a great question. And it's another, again, not to harp on this idea. And again, we have all worked or volunteered or currently working or volunteering for SSPs. We love all of our syringe access friends. But, this, push of like, oh, we need SSPs to reduce bloodborne disease infection is, has resulted in this situation in a lot of states where even if SSPs are permitted to distribute syringes, they are not permitted legally to distribute smoking equipment. And that's terrible, like Amy said, for most people, switching from injection to smoking is a harm reduction activity. That's something that, is good public health. And as the fentanyls infiltrate the opioids, the straight opioids, it becomes particularly important. And yeah, we're seeing like people are voluntarily moving from injecting to smoking. I mean, we hear from people who say like none of our participants even want syringes anymore. Everybody just like, we can't keep pipes in stock. And that's not because like some PhD in the health department is telling them. That's because like people are smart. Like they understand their lives. So again, just another example is like how sort of the piecemeal way in which laws that, the overarching concern is we still need to make sure that we are criminalizing and harming people who use drugs. We're willing to make specific carve-outs to that. Just doesn't work. It's not good law. It's not good public health.
And I think that's, I know we're almost out of time, but that's just another thing that we've sort of danced around in this webinar, but not really addressed full stop, is that the things that help people who use drugs, you are not going to find out what they are by making decisions for them. You're going to find out what they are by talking to them. Talking to people who use drugs and saying, what do you need to make your life safer, less confusing, less difficult? What can we do as harm reductionists to, in this world full of people that don't care if you live or die, what can we do to make life just even a little bit easier for you?
All right. I think that we should let that be the last word. Thanks for coming. Yeah, these slides and the recording are going to be available on our website. Please drop us an email if you have any questions. We are just harm reduction at network.forphl.org, or just Google us. We're there.
We're also on Twitter and Instagram at Harm Reduction Legal.
Great. Thanks again for coming, everybody.